Okay, good morning, class. Today, let's discuss about the very important topic for FMG exams, that is acute scrotum. So, I think you should know basically the content of scrotum first. Let's see the content. So, you see the scrotum here. So, this is the sac scrotum. Okay, that contains testis, epididymis, and the vast difference, and obviously surrounded by 5-6 layers of the scrotum. You know that very well. Okay, and there is tunica vaginalis. Fine. So whenever we say acute scrotum, it means that whenever there is a sudden onset of the pain and the swelling in the scrotum is acute scrotum. Okay, it means sudden onset of acute pain and swelling at scrotum. Okay, so if you see the differential diagnosis, the DD or differential diagnosis, then you'll find the common causes are, so very understandable. One of the common cause is infection or inflammation of testis and epididymis, known as acute epididymoarthritis. So acute epididymoarthritis. Second one is the twisting of the spermatic cord, right? So this is the spermatic cord. The cord may twist around, okay, known as torsion testis. Torsion testis. These are two most important cause of acute scrotum. The other cause as well, there is one small structure known as appendix of testis that can be twisted. Okay, so twisting of appendix of testis, or you can say torsion of appendix of testis, and there may be trauma of any region. Patient may be playing and there's a hit by the ball, or someone kicked the testis. So trauma also causes pain, and there may be skin infection, like you can say a diaper rash in the baby. So that one, okay, diaper rash, or any inflammation of skin inflammation that may cause the pain around the scrotum. And whenever there is a stone in the ureter, ureteric stone, so that stone in the ureter can have radiating pain towards the testis. Okay, so radiating pain to testis, especially you can say example is ureteric stone. Okay, so these are the common causes, and the most important one for the exam point of view as well as for your clinical practice. One is the acute epididymoarthritis, other one is torsion testis, because acute epididymoarthritis is common due to the sexually transmitted disease, and torsion of testis is the urological emergency. If you don't treat the patient on the given timeline, then the testis may be damaged. That's why it is emergency situation. That's why these two are commonly asked, especially the torsion testis. Okay, so now let's start torsion testis. This is the differential diagnosis, as I've explained. Focus on mainly torsion, which is important for exam, and also you'll find a lot of cases of STD causing the epididymoarthritis. For example, there may be mumps arthritis, which is not STD, but still there is a chance of mumps arthritis, and STD may be due to chlamydia or gonorrhea. Okay, Now focus on torsion, testis. So see here, you can see there's a twisting of the spermatic cord. As you know, the spermatic cord contains so many structures. The one of the most important is vessels. So suppose this is testis, okay, there's the vast difference. Spermatic cord contains with the scrotum, okay, and you know it's supplied by the testicular arteries and also the pampiniform venous plexus, the veins surrounding the arteries. There's also lymphatic tissue, lymphatic lymph nodes, lymphatic structures, and also some fat there, some fat, okay, so on. So torsion testis basically means there's a twisting of spermatic cord. So torsion means spermatic cord is twisted, okay. And what's the problem here? If there's a twisting of spermatic cord, as you know, there's a decrease blood supply to testis. That means there will be ischemia. Ischemia means, as you know, ischemia lead to what? There's hypoxia, ischemia that lead to testicular damage, and it causes severe pain. And if not treated on time, then it will cause testicular damage. That's why it is known as urological emergency. Okay, it's important. So see, all the male will not have this disease, right? So there are some risk factor that lead to this disease. Okay, before that you have to understand the risk factor. Number one, if there is high investment of tunica, vaginalis, it lead to clapper in bell phenomenon. I'll explain what is that. The second one is whenever there is a mesoorchium present. Let me explain. So suppose this is the testis, which is normal, okay, and it is surrounded by the tunica vaginalis, which is not completely surrounding, just sorry, and it will not surround the epididymis, okay. It will only surround the testis. The epididymis is free. This is testis, okay. And if you do a cut section, then you will see that this is testis, this is epididymis, okay. And you see the tunica is surrounding the testis but not the epididymis. This is normal, fine. But in the case of clapper in the bell, or you can say the high investment, what happened here is the testis, okay, is completely surrounded by the tunica, completely, okay. So this is a problem. Now it is free to move. If I cut it and show you under the cross section, then this is the testis. Wait, this is the testis, okay, and this is the epididymis. The tunica will be completely investing the testis and epididymis. That means it is freely hanging and it will not twist easily, compared to the clapper in the bell. Clapper in the bell means, suppose this is the bell, okay, and this is the clapper. It is just like hanging like a clapper in the bell, which is easy to twist. And sometimes the patient may have the testis. See here, this is the testis. Normally there should not be gap between the epididymis and testis, but in this patient there's a gap again, and this gap is filled by a membrane known as mesoorchium. Okay, this is mesoorchium. Is a congenital defect, obviously. So if you see the cut section, then you will see This is testis, and there's a gap which is filled by the mesorchium. The tunica will be normal here. Okay. And now it is free to twist at this point, so leading to the torsion testis. So one is the clapper in the bell phenomenon, clapper in the bell, or you can say it is due to the high investment, and this is mesorchium. And this is a question in exam. They may ask you what is the defect that lead to the torsion testis, and commonly it is clap in the bell, or you can say high investment of tunica and mesorchium. These two are important, don't forget this one. And this is the picture, you can correlate with this picture as well. Okay, so fine. Now let's see how we diagnose a case. Okay, how we diagnose. So obviously whenever we see about the diagnosis, you know that we have clinical features, right, and we do some investigations. Okay, mostly it's a clinical diagnosis. As it's a urological emergency, we depend mostly on the clinical feature, but if we have time and if we can do the investigation, we do that as well. So clinical feature, if you see symptoms, so if you see symptoms, the patient complains that he has a sudden severe onset of the pain in the testis as well as swelling. So sudden severe onset of pain and swelling at scrotum, and he may have similar kind of pain in the past as well. Someone will give history of similar attack before also. Okay, some. And if you examine the patient, then you will find very classical features, like you can see here. Number one, you will see the testis lies a bit horizontal, because as it twists, it will go upward. If we twist, it goes upward, right? So the testis is vertical, so it twists, it goes upward like horizontal. So if you see the testis, it lies horizontally and lies above, so it is slightly above in compared to the unaffected testis. Number two, if you palpate, then it is very severe, painful, that is tender. It is tender. And if you see, there is a swelling as well. Okay, and there are two signs which is very much important. You have to remember those signs and the meaning of that sign as well. Those are Rabinowitz sign. Rabinowitz sign means the loss of cremasteric reflex. This is the positive. Okay, means, so see, suppose this is the thigh. Suppose, okay, this is the thigh. Okay, draw properly. So this is suppose thigh. Okay, here is scrotum with the testis. So if you stroke the medial aspect of the thigh by finger, the testis will be lifted up because there is a cremasteric muscle which will pull the testis upward. Okay, cremasteric muscle. This is known as cremasteric reflex. Cremasteric reflex. This is normal. Okay, it is normal. It is always present there. But if there is a torsion testis, that means there is a ischemia of the muscle as well. So you'll find there's a loss of this reflex known as Rabinowitz sign. Sometimes they ask this in your exam, so remember this question. Don't forget this one. Prion sign. Prion sign means is very understandable. If you lift the testis, If you lift the affected testis, what will happen? So it will twist more, such that it will cause more pain. So more pain. Usually, if there is an inflamed testis, like in the case of acute epididymitis, if you lift, okay, it will support. That support will decrease pain. Here, if you lift, it will go upward and twist more. That's why the pain is more. That's why in the case of torsion testis, this sign is negative. Means why negative? Because usually when we support, the pain should be relieved, right? But here it is increased. That's why we say negative presence sign. The meaning is if you lift up, it will have more pain. And this is very important sign. Don't forget this one. For exam is very much important. Okay, they ask this one. So after this, knowing these signs, sometime in emergency situation, this is enough to explore the scrotum, open it and see. But if you have time and if you have the resources, if you can do, then better to do Doppler ultrasonogram. Okay, the best investigation is Doppler ultrasonogram of scrotum is the best investigation. Again, this could be the question in the exam. So what is Doppler? In Doppler, what we do, we see the vascular flow, right? So whenever there is a torsion, you know that it will be reduced, right? So you see this is the right side testis. You can see here, this is the right side, this is the left side. You can see in the right side, the vascularity is almost absent, right? There is no vascularity, it is not here. But in the left side, you can see there is a vascularity. Left is normal, the right is having reduced blood flow, indicating torsion testis. So this is diagnostic for the torsion testis. Okay. Now, how to manage? So the principle is do detorsion. Means do detorsion means just as soon as possible you just do a detorsion manually or surgically, such that to prevent the ischemia. So in emergency you can try manually. Means just hold the testis and twist outward. Okay, twist outward. So manual detorsion means twist testis outward. It's easy to say but difficult to do because patient is already in the pain. We can start with the anesthesia also, but the thing is mostly it's difficult. So the best one is do surgical exploration. Means open and see the scrotum. If you open and see, then by that we decide what to do. See, so there are two testes, right? So you have to decide for both testes here, affected testis and normal testis. So affected testis, if you see the color change, it is pinkish. Suppose pinkish means it is still okay. Then you do fixation known as orchiopexy or orchidopexy. If it is blackish, it's already necrosed, then do orchidectomy. Remove it. If it is bluish, still confused what to do, then what you do, wait for 10 minutes. You give increased oxygen supply, cover the testes with warm mop or cloth, and even you can prick and see the vascularity. Wait for a while, 10 minutes, and if the color changes to pinkish, then save it. Still bluish or convert to blackish, then remove it. So this is the way how we decide after exploration. You can see this picture here. Just wait. Okay, fine. So okay, picture you can see from here. See this is the normal pinkish one. This one you can see the blackish, already necrosed. We have to remove it. If it's bluish like that, then wait for a while and give the oxygen, increase the saturation, and then you can cover this by a warm mop. The warm mop will increase the vascularity, and if it is normal, and then you can see the color change in the blood. If it signifies it's still bluish or blackish, then remove it. If not, it convert to pinkish one, then you can save the testis. Okay, you can save the testis. So now the question is, what about other testis, which is normal? So don't wait for the future to have a torsion. So fix it on the same setting. You have to do bilateral surgery. So it is orchiopexy. That means the answer is I have to do a surgery in both side. Both side. Affected side we decide by the color change or the necrosis or not, but the normal side we always fix it. We always fix it. So you can take a vicryl and fix it in the scrotal sac. Okay, open and fixing is the answer. If it is still okay, if not, then you have to remove it. Now the question is, what is the golden period? What is the ideal time? Okay, this is very important for management as well as for the question in exam. Timing. Okay, the golden period is 4 to 6 hours. If you can do this surgery within 4 to 6 hours of onset of pain, then you can save the testis. If the patient come to you late, suppose if they come to you more than 24 hours, then only 20% chance of saving the testis. Okay, so here the time is the money, right? So if the patient come to you on time, then don't waste it. Confirm. You can confirm by Doppler. If you don't have time to confirm, you can still open it and see and decide what to do. So this is the way how we do it. And then this is archaeopexy. Okay, and there's a difference between the testicular tumor and epididymitis. Very important to understand. So see, because you in both cases you'll got a patient who are young adult, like 30s, 20s and 30s. So torsion is also common in that age. Epididymitis is also common in that age. So the difference is, number one, how it start. So see, torsion is always acute, sudden onset and severe pain. But in orchitis, there must be STD or mumps orchitis. So patient will have a gradual onset of pain. They will say, yes, sir, I was having pain for a few days. Now it is increased. So there's a gradual onset. Okay. And obviously, if they give you the history of the sexual contact, that's fine. You will find the history of sexual contact as well as the sign of STI, like urethral discharge, or dysuria, like that in the case of orchitis, whereas in the case of torsion, it is not there. As I have told you that the testis will be horizontal, high riding in the case of torsion, normal in the orchitis, right? Cremastic reflex absent usually in the torsion and present in orchitis. Present sign, if you lift the testis, it is more painful in torsion and the pain is slightly decreased in the epididymitis. And Doppler is the best investigation to differentiate. Understand here, if there is torsion, there will be decreased or absent blood flow. In epididymitis, as it is inflammation, there will be vasodilatation and there will be increased vascularity in the orchitis. Okay, so management, as you know, orchitis usually STD, we give analgesic as well as antibiotic support, and torsion is a urological emergency. Explore it and decide what to do. So remember, this differentiation is important for your clinical question solving, as well as important for your your clinical life. You can have patient like this one. And let's see a video here. See, here is the patient having the left-sided torsion. You can see that is slightly high up, as well as there is shiny skin indicating that's inflammation. And let's explore from the midline. Midline exploration is started. Okay, and cutting different layers of scrotum. Fine. Let's see. Okay. We are using the cautery and opening the midline. So we'll first go to the affected side. Okay, and it's still uh, already visible is slightly blackish. Okay, so open it and see the color. See, it's already blackish there. So explore it. Okay. So you can see the color change there. So you can see here, wait, yeah, see the color of the epididymis is already bluish blackish, and the text is also not normal. Normal is pinkish. I'll show the other side as well. So now we have to it is almost necrotic, so we have to dissect the spermatic cord, make the structure free, untwist it, and again confirm it. Okay, there's a twisting there, so untwist it, and then we have to remove this testis. Okay, it's not easy to untwist because it's already like few days old, so you have to dissect the spermatic cord and then make it free and untwist and see and decide. So let me fast forward the video slowly. So exploring. Okay, wait. Yeah, you can see the color change here is very dark. Okay, you can even check by pricking it. You can see the black clotted blood is there. It's already gone, right? So we'll dissect here. Okay, and once we get that area free, then we will clamp, cut, and then ligate the vessels and the cord. So dissecting now. Dissecting. Okay. So once it's free, now we'll do a double clamping. Okay. One clamp, another clamp, and then cut. Okay, cut it. And that now between the clamp you can do you can tie the vessels. Transfixation. Then once it is done, you can free up the clamps. Okay, fine. So testis is removed. This is the affected side. Now you have to open the other side at the same time. From the same incision you can open it, and now you see here that how the normal testis look like. So wait, tunica is being opened. See the normal color. Now we have to open the tunica, and then we fix the testis to the scrotal sac, so that in future there will be no torsion now. See the color of the normal testis is very pinkish whitish in color. So now we have to fix it to the scrotum. It's fixing now. See here, fixing. This is orchopexy, and then I've done the surgery. Okay, I hope you understood. So fine. So the topic is over. Then we will discuss other topic next time. Thank you.